Thank you very much. We have half an hour for questions and also for summing up. Normally in sessions like this, we find the time is consumed by speakers leaving very little time for question answers, but I think our speakers have been great. They kept the time, and so we have about 25 minutes for discussion. And we have two speakers who spoke about the funding, the two top funding agencies, PEPFAR and Global Fund. We have an academic institution doing some great modeling and showed you where the investment should go. I tried to give an overall picture from the UNAIDS point of view and also from my own little experience as an implementer in India. So I think the floor is open, and please take the mic and and let us know to which speaker you are addressing your question. And please introduce yourself also.
Yes. Jorge Saavedra is Healthcare Foundation Mexico. And my questions are one for Christoph Ben and the other one for you, Dr. Prasada. So the first one is about the Global Fund, because it looks like there is a struggle there about being more evidence-based prescriptive in order to be more effective on the use of resources. And then there is another struggle there to leave more country ownership. So for me, it's kind of a contradiction to be more effective and more prescriptive, and then to leave it to the country ownership. Of course, country ownership comes from domestic resources. They feel that they own those resources, so they are about to decide how to use them. On the other hand, I don't know if in your current status, Dr. Prasada, you can tell the new Minister of Health of India not to waste the domestic resources of India in new abstinence and be faithful policies that he was quoted to announce that he was going to launch. So that's a clear waste of resources. So someone needs to tell him directly that that will be a pure waste.
Thank you. Christoph?
Yes, thank you, Jorge. I mean, that is clearly the dilemma. And the Global Fund clearly has evolved on this question because, as you know, when the Global Fund was created, the principle of country ownership was the most dominant principle, if you like. And we left it to the country to kind of develop their proposals, to this round-based approach. And now we have not moved, to be prescriptive, but we've built in this element of an increased and enhanced country dialogue so that we can sit down with all the partners at the country level and analyze the data and then come jointly, to a conclusion how we invest the money more strategically. So it's a fine balance, if you like, but you're right that the Global Fund has moved more to a stronger involvement also of the Global Fund Secretariat in discussing with the countries, how the money will be used in the most strategic way.
Yeah, so far as your second question is concerned, I think the statement of the minister raised some concerns, but definitely the fourth phase of the National AIDS program, which was approved by the government, has all the essential elements of prevention, including condom use. I don't think there will be any dilution of priorities on that. It was an opinion expressed by the minister that ABC approach, the abstinence, be faithful also should be there, and condom should not be the only one. That doesn't mean condom should not be there. He never said that. I think there has been some misrepresentation of what he said in the media. So I can assure that the commitments made in the national program, they stand even with the new government, and definitely there will be quite a number of us who will be watching the performance, will be vigilant about it, and definitely will not hesitate to bring it to the notice of the government if there is any departure from that particular position. Thank you. And now, next question.
Yeah. My name is Shubha Raghavan and I'm from India, and this is for Dr. Deborah Birx. I have a three-part question. One is we really commend USAID for transitioning the funding to local NGOs, but you're also requiring local NGOs to build their capacity to handle this large pots of money. So I would like to know what efforts you have in place or resources you're allocating in building the capacity of the local NGOs. You also don't allocate indirect costs for some of the countries. And so in absence of the indirect cost, then it will be difficult for us to accept these grants and also implement these programs. That's one question. The second is about the quality indicators. How are you working with PEPFAR, with the Global Fund, in harmonizing the indicators? Because we have agreed that we will not have two sets of different monitoring, because we've all agreed on harmonizing our monitoring. How are you going to work with that? And another complex, there are two parts of the complex nature of quality is that how are you working with the countries' national programs and quality in integrating these, because they may not want to have such ambitious. And third is, as you move forward with the integrated programs with MCH and others, you also need to ensure these quality indicators are harmonized with the entire national program, which is very complicated because many of the countries do not have very good quality assurance programs. And how are you going to do that in a stepwise fashion? And do you have a systematic process at the country level in addition to the global level?
Great. Well, fortunately, I wrote those down. So, so thank you for raising the issue about investment in local NGOs. It's been an exciting time over the last 5 years of PEPFAR because a whole series of agencies have moved to local investments. And so in some countries, all of the funding is through local ministries of health, NGOs, local universities. And to do that, there have been capacity building technical assistance, and there is a parallel technical assistance piece for building those capacities, and that still exists. The quality indicators, how are these developed? So the quality indicators that I posted from what CDC had been utilizing for the last 3 years were developed from the Global Fund site level indicators, Global Fund indicators, GIZ's indicators, DFID's indicators, and the Ministries of Health indicators, and it was guided by that. The visits that have occurred, those 3,444 site-level visits, occur in partnership with the Ministries of Health or the NGO local partners. So those are done in, and those are compatible with the national level guidelines. I had in a different talk this morning, and I think you raised the last part of your question, I think is quite important. This was brought to me in a meeting that we've had with Ambassador Shaw about under 5 survival. And we now are mapping the prevalence of under 5 mortality, high levels of under 5 mortality with the high levels of HIV prevalence, so that we can ensure in our quality indicators that we're looking at improving the under 5 survival as well as the HIV clinics at the same time. So this is an exciting time to really working across the health system in a more impactful and actually measurement-based way so that we can really see if we're having what UNICEF is describing as the double dividend, and we're excited about that opportunity. So thank you for your question.
Thank you, Deborah. Yes, please.
Cipriano Martinez from Australia. I guess I would like the panel to just make some comments around how could we actually build and increase transparency of our organisations, because my understanding would be that if there is more detail, then people with HIV and the public can really scrutinise some of these decisions. And if you actually have the actual people who are making the decisions and the money that they're actually allocating so that people can then be appropriately made accountable, what can you do to actually increase the transparency? Because one of my concerns is that a lot of the slides that are given in such aggregate. There's no way for someone to actually, scrutinise this and come to conclusions around cost effectiveness, cost utility or cost benefit analysis. So where is that transparency? Thank you.
Thank you. Who would like to take that question?
We agree with you completely that if it's not down to the level of the site, whether it's a community site or a facility-based site, there's not enough detail to make those type of decisions, and you do usually see composites. And we're committed to, at least within PEPFAR, to move the analysis and the available data to the site level. I think that's the only way you can really understand when a site is having a difficulty or not, or whether it's providing quality and as well as an effective response. So I think you'll see a lot of interest in that level data. And I think once one organization does it, everybody then will move and do it also.
Yeah. Fully agree. Transparency is extremely important also for the accountability that I think all of us want to see with this investment. In terms of the Global Fund, you might check out the website. What you can really follow in a very transparent way is, where the money goes at to the country level, to the grant level, per disease, per recipient, the disbursements when they go. You can also see all the information about the prices, for example, which is a very important component of that transparency, that the countries can also compare what kind of prices they pay for drugs and other commodities, for example. It doesn't go down to the community level, if that's your point. I mean, it goes down to the kind of grant level where you can see where the money goes and also what is being done with the money, what we call grant scorecards. So that's...
So I'd encourage you to go to the next level as well, because that way people can really get involved and ensure that the investment is as optimized as possible.
Just a really quick comment on that, because I think what has been valuable to us is within the same country and in different sites, you'll see extraordinary quality at a very low cost, and really providing that south-south connection between different sites. That's where it needs to happen, and it can't happen if you don't have the data down to that level.
Thank you. Next speaker.
Thank you. My name is Jim Sultan from the United States. First, thanks to all the panelists for some excellent presentations. I am concerned somewhat with the discussion about Africa, although it was good. It was focused on Southern Africa and to some extent Western Africa. I'm concerned about Sudan and South Sudan in particular, which before they were territorially divided were composite of Africa's largest country. And then there's all of North Africa. Why is that being seemingly ignored?
Let me just mention quickly the South Sudan and the Sudan, and we share your depth of concern. And if I could just spend a moment calling out the dedication of local partners in these difficult situations. We have a significant number of people receiving HIV services in South Sudan, and they have continued throughout all of this difficulty and conflict to provide life-saving services, prevention, care, and treatment. And it's always remarkable to me that when oftentimes we will have to leave immediately, our implementing partners in our host country continue on as we provide them the commodities and the ability to move forward. So we've seen that in country after country, and it gives us great hope for how to work in both conflict and post-conflict regions. So thank you for bringing it up.
I'd like to add to that despite a lot of the complexities and difficulties in Sudan, they've taken a bold step in their leadership just recently. They've recently submitted a concept note to the Global Fund that substantially shifted the distribution of their funding from their old models. My group with the World Bank assisted them in doing that, and it really was a very, very bold step. So they are starting to do things very smartly, and there is a lot of support for them.
But let me add that I think North Africa, Eastern Europe and Central Asia is still a very challenging region, and this is where we are seeing increasing number of new infections occurring. So if you have to realize that goal of an AIDS-free world or AIDS-free society, I think a lot need to happen there. And we also have the handicap of inadequate data from some of these countries. So I think just wanted to leave it.
Just one point. In the interest of time, I had not presented all the percentage changes per regions there. But if I had, North Africa, Middle East received 50% more in the allocation of the Global Fund recently. And Sudan and South Sudan, in our terminology, is part of North Africa, Middle East. So it's an important part of that increase. So that's even more than the rest of Sub-Saharan Africa.
Thank you. Yes, sir.
Thank you very much. My name is Rick Barazal in the United States. The question I have really has to do with the use of mathematical models in general. So, David, you may want to take this, but I think some of the other members of the panel could also address it, which is that as we continue to use more intensively mathematical models to get at issues around efficiency and projecting out and so forth, all of our models are only as good as the information and the data that we put into our models and the assumptions that we make and that sort of thing. And so most of the low-hanging fruit has been taken with respect to how we might move forward in prevention, care, and treatment programs. I'm wondering what sort of adjustments do we need to make and can we make in our mathematical models to get at these issues of efficiency because resources are much less available. But yet we're having to go after populations now that are much more difficult to go after. Young people, MSM, sex workers, and so forth. Groups that have always made up the bulk of the epidemic, but now make up a greater percentage in total of groups that we need to go after. So how can we develop our models realistically under these circumstances? What kinds of adjustments can we make when we don't necessarily have that kind of data available in order to better plan our programs?
Program responses should be based on the epidemic. So fundamentally, we need to know our epidemic. So surveillance data, monitoring data is of foremost importance. If we do not have the data, then models are not going to be useful because we don't have input data for them. Models are just tools. They're abstractions of reality that try to provide you just a little bit more insight into the data that you've already got. So it all starts with the data. If we're looking at other harder-to-reach population groups, well, there's very little data around the transgender groups. That's a major gap. We need to have data that looks at trends over time. It needs to be done in comparable manners, so you can look at whether there are increases or decreases. Otherwise, it comes down to surveillance. So I think the models don't need to be made more complex. All they are to do is to provide just simpler insights into the data that are available. So it's all fundamentally driven by good surveillance data.
Thank you.
Just a quick note on that. In our expenditure analysis, and I think you point out an important point, you have to compare like to like. But in a region, and when you're doing an expenditure analysis down to the site level, and you see that for reaching transgenders or MSM, it ranges from $5 to $500 within the same region. Then it gives you the ability to dissect down, is that a different quality program? And that's why the quality data is so important. But the expenditure analysis allows you to do that comparison of like. So you can't really compare MSM programs to general population programs. You have to really compare them within each other, but even in that comparison, you can have huge breakthroughs in understanding how to become more cost effective.
Thank you. Please.
Thank you.
I think we have just about another 7 minutes time. So if you can make the question shorter, I think that.
Okay, yeah. I have actually two questions. One is to David. We have a pleasure to collaborate on the study. I'm Andrei Klepikov from AIDS Alliance Ukraine. But I would like to bring your attention that you identified some optimization and some reductions. But actually what happened during the recent submission of the new funding model proposal to the Global Fund, that costs for drug users reduced by 50%. Much more substantially than you recommended. That's I would like to bring your attention that because some of the conclusions were misinterpreted. Harm reduction is expensive, let's reduce it. Substitution therapy is expensive, let's reduce it. But in reality, we have now the most cost-effective program, perhaps, harm reduction in the world, because cost per client used to be $30, now it's 15, but it's unreasonably low, and there should be a mechanism not only to justify optimization of the cost, but a flag where it goes too low. And second question is about the politics, because I'm from Ukraine, and all our plans for sustainable national funding, for example, crashed. Our budget goes to, national budget goes to war. War we are having with Russia. Russia annexed Crimea and now supporting terrorists. So our budget for HIV/AIDS is reduced by 70% according to the plan in this year. Our budget...
Can you make the question shorter, please?
Yeah, our budget for HIV from the Global Fund for 2015 will be reducing by 62%. So what, in terms of the politics, so this question is more to Christoph, Deborah, and you, Prasada. You shouldn't be just observing this, that funding is dropping dramatically, because if you will be observing epidemic, it will be growing up. So what is the emerging strategy in such situation as we are facing in Ukraine? So.
Okay, thank you. Christoph, would you like to?
Well, Andre, that's a very challenging question, obviously, and we've been working, on the program for many years, and we see with great sadness, what is happening in the Ukraine. And unfortunately, we have no kind of contingency funding for this kind of situation. But you also know that, we've been quite active in a sense, trying to discuss with you and the colleagues in the Ukraine how we can, address the situation, but some of that is obviously beyond our influence.
Thank you.
Just a quick comment. I mean, we understand the difficulties, and we do have a bit of a contingency fund, and we did increase our funding to the Ukraine in 2014 for these very reasons.
Okay, thank you.
Krista Lauer from Canada, working with the Open Society Foundations. What an exciting time. Both PEPFAR and the Global Fund have clearly highlighted the need for human rights in reaching key populations. We know that in many cases, the most effective organizations doing that work are national NGOs, regional level NGOs working on difficult issues such as legal empowerment of sex workers, people who use drugs, men who have sex with men. Funders concerned about AIDS and UNAIDS recently did a mapping of 123 NGOs working at the intersection of HIV and human rights and found that many of them are in funding crisis, some of whom have had to close their doors. What opportunities do you see for the Global Fund and PEPFAR to support those organizations? Thanks.
Thank you.
Thank you. I'll be quick so we can also hear from Global Fund. I think you probably are aware we've launched a new large local capacity initiative to increase funding support for the very organizations that you described. My concern, though, in going out and talking to communities was that and it gets back to the NGO question, a lot of the absolute critical grassroots groups, the groups that we would really want the funding to go to, didn't have computers to write up the response to the concept note to apply for the funding. So we need to actually figure out a way to do this better, and we're in conversations right now about whether this should be umbrellaed through the current investment strategy with local and regional NGOs, but thank you for raising that.
Thank you.
Krista, we fully agree on the kind of strategy, and we have a very clear strategy on human rights and on, supporting key affected populations. How then translates into the concept notes? That's again going back to the country level dialogue. It's not always easy because it's not always recognized by all the partners, and we have countless meetings. I had one big meeting here this morning with a lot of groups here from this region exactly on that, and how we can strengthen their position, if you like, in these discussions. So that's an ongoing process, and there is a lot of work also partly with you, in a sense, to strengthen that, to build the capacity in those discussions. But the direction is very clear. I mean, we want to see more funding going to key affected populations and implemented by exactly the groups that can do that and have the access to the key affected populations.
Thank you. I think we have just time for two more questions. I think two more. I think you are standing here for some time. I would like to ask both of you to have your questions. Others, please sit down, and maybe you can meet the speakers after the session is over and have a conversation with them. Yes, sir.
Thank you. My name is Kazim. I'm from Nigeria. I'm working on a study that's looking at the impact of HIV on the HIV funding on the wider healthcare system. So my question is both to Deborah and to Christopher. So my question is, are there any thoughts or any mechanism to look at the impact of HIV funding on the wider healthcare system, on wider healthcare services? Because we know that obviously the healthcare needs of a country is the responsibility of that country's government. But we also know that large influx of funds, especially to poor countries, can change the priorities of individuals and organizations. For example, are there thoughts to make sure that in order to meet the counterfund funding for Global Fund, for example, that governments are not moving funds from equally important needs into the Global Fund project? I've also read a study that says that saw like 25% movement of healthcare people, doctors and medical professionals from public service into Global Fund project, sponsored project, for example. So I'm just saying, are we making sure that in order to solve a problem, we are not creating another problem? Are there any mechanisms in place or any thoughts to just avoid sort of a problem like that? Thank you.
Yes.
Start this time.
Let me start this time. We're very much aware of that problem, and we're also aware of, previous studies that have looked into that. We're not doing any of those studies or analysis ourselves as the Global Fund, but we are looking into that also as part of this country dialogue, because indeed, the money should not, be to the detriment of other very helpful programs. But it's not that we as the Global Fund have the mandate or the capacity to kind of do country by country studies on that, and how we can address that.
I'm glad you raised Nigeria, because I think all of us are deeply concerned about the lack of a real impact on the epidemic there, the poor coverage for pediatric and adult care and treatment, and the continued raging of the epidemic in Nigeria. And I think as a collective, it is something that the partnership between the Global Fund and PEPFAR and the country are taking quite seriously, and we've had a long series of meetings about Nigeria. But I think that what would be helpful is if you write about the investment the country is making in HIV/AIDS compared to other countries in sub-Saharan Africa, and I think that will be a telling piece for all of us.
Thank you. Last question.
Thank you. My name is Patricia Rivera Scott from Guatemala. I'm working with the PR for Global Fund, Civil Society, EVOS, and I had one question regarding the new funding model. When you talk about willingness to pay by the countries, it's we both distributed among the three key approaches, malaria, TB, and HIV. So how can we avoid, because it's brilliant to make countries aware of the need to coordinate and have a transfer of knowledge from one of the other responses to the rest. But yet it's a little bit disincentivating once the HIV is stronger response and the other two are not doing so well. How will this not affect the 15% that is supposed to be assigned for HIV response? And a broader question to all of you is, how can we talk about civil society sustainability mid and long term in an era of more and more medicalized response? Thank you.
On the willingness to pay, we recognize contributions of the government on all three diseases, and actually also on investments in health system strengthening as it relates to the three diseases. That goes also back a little bit to the previous question. So it's not just, the kind of disease-specific funding that we are looking at, but we encourage the governments, if you like, to invest more in the three diseases, but also in the health systems, because that's absolutely necessary to implement the programs. We've been a strong supporter of funding going to civil society in many different countries, and that will not change at all with the new funding model. And we are, making sure that civil society is included in this country dialogue and in the preparation of the concept notes.
Thank you very much. And I will now turn to co-chair Michaela to make the closing observation.
Thank you. Sorry. Thank you very much to all of the speakers. Being a human rights person myself, I was particularly happy that Krista raised the question that she did. The same, just a short comment. The same study that she was referring to also showed that in 2012, less than 1% of the total spending on AIDS went on human rights programming. So if we are really that committed to making sure that human rights are at the center of the response, I think we really do need to think about scaling up support for human rights programming. So I'm sorry I took the little opportunity to plug my human rights bit in there, but thank you to all the speakers. It's been a really stimulating session. Thank you to all of you for your participation and questions. And thank you to my co-chair, Prasada. Thank you all.
Thank you very much.